forum and to act as sponsor for some of our projects. And I think that's really important. It's obviously a part of the culture now at ELFT that everyone is involved in quality improvement in some ways, and certainly people with kind of management and leadership responsibilities need to be taking an active part in sort of QI processes and structures in their directorates. So I think the QI model for improvement is really important for staff morale because it starts off with the assumption that everybody who's involved in delivering service and delivering care has the ability to improve that service, that it sort of takes ideas for improvement from everyone working in that service. It empowers individuals to make suggestions and to make changes themselves, regardless of how senior they are or what kind of role they're taking. So I think it has a really positive potential for improving the way that people work and also improving the way that people feel about their work. So engaging staff in QI is always going to be a bit more difficult, I think, than for people for whom QI is part of the day job, because we know that everyone is very busy and working very hard, and they have enough to do without having to take on what seems like a whole other role. I think one important way of engaging people is to encourage them to do some of the QI training. The QI pocket training is really helpful to give people a very quick and efficient idea of how the model for improvement works and the potential it has for making their working lives easier, of getting to these sort of the stones in people's shoes about their day-to-day work that makes things more difficult, and fixing those in a very sort of easy and very structured way. So through training, also through sharing stories of our improvement projects, through newsletters and directorate meetings and other similar events. I think although at the moment we have a good group of people who are leading QI in the directorate, that doesn't come for free, and we need to make the effort to keep on identifying new people who can step into quality improvement roles, both formally and informally in the directorate. I think one important way of doing that is keeping in mind the schedule of future QI training, so the Pocket QI, also the improvement leaders and the QI coaching training that's coming up over the next 6 to 8 months, and starting off early to identify people who might be suitable for that training, which gives us time then to make sure that they have the time and the support of their managers to engage in that training. There's nothing worse than having to scramble around at the last minute to find people to do the course who are then kind of not really committed and not really supported to do it.
In Newham, we have a strategy which I did implement after seeing how we can improve quality improvement. So we start by, because we have bi-monthly working together group meeting, Susan and carers come together, and sometimes we invite staff to come in and talk about any issue, including if they have quality improvement projects. And services and carers can listen and be interested to join the QI project in order to involve in the process. Focus group in different teams in Community Health Newham services, and those teams, when I go to talk in their meetings, I talk about quality improvements.
Model for improvement gives us a really helpful framework for thinking about some of the harder and knottier problems that we're encountering as we develop our expertise in providing community health services. One really good example is our work around pressure ulcers. Pressure ulcers are a well-recognised source of patient harm. There's been a lot of focus on them in the hospital setting for a long time, and increasingly now in community settings as well. We know that our rate of pressure ulcers that were being developed by patients we were looking after in the community was too high, and so we decided to make that a priority for our quality improvement work. I think it's a good example of something that maybe would have seemed too big and too complex an issue just to try and fix it with kind of traditional methods of sort of management and change. But the QI model allowed us to break the problem down to a number of smaller areas that were easier to fix and easier to solve.
QI feels really different now to what it did a year or so ago, and the reason for that is because we usually did projects in-house, so it felt very safe. You were talking amongst colleagues and people that worked in the organisation. So I think where we're at now is the QI projects have become more integrated and sort of exposed, if you like. So we could be talking to anybody in the room at a QI team meeting. That might be other organisations, other providers, CCG, for example. So I think we've gone from a place of feeling safe to now actually it might feel a bit scary, but actually it's very exciting as well. And I think that staff are being supported in doing that through our QI coaches and through our sponsors. So I think that's really helped us to really take forward integrated QI projects within community health services.
As a sponsor, I don't get involved in the day-to-day sort of running or sort of development of projects. I see my role as being partly a kind of a critical, supportive friend to the project, so to be able to keep an overview of what the project's doing and how that might fit into other work that's being done elsewhere in the Directorate and elsewhere in the Trust. Making sure that the project lead is supported and has the resources they need to do the work of improvement for their project, and also making sure that they're keeping on track. There's obviously a temptation for projects as they get more involved to identify lots of other problems and lots of other things that need fixing, but I think it's an important role of the sponsor to keep their project leads on track and sort of focused on their initial aim.
I've been involved in about 4 QI projects so far. Out of those 4 projects, I've been project lead for 2 of the projects. We've had a range of people involved in our projects, so that includes service users and members of the CCG, so that's been really interesting and really exciting for us. As a project lead, it's really important that it was an interactive discussion at the team meetings that we had, making sure that everyone had equal input into the discussions and that we all had the shared aim that we set out to sort of achieve through the project.
My role is about to facilitate the working partnership between service users, carers, family members and the staff in order to improve services. Sometimes it's quite difficult for staff to change their culture of working and accept that people from outside can come and tell them or suggest something new to them, that the way that they have to work or they have to improve their work. And also it works the same way to the service user, because it's the people that you don't know. You have to build that relationship, that trust, for them to see really, am I going to improve something? Because they know the way that NHS services have been delivered in the past. They may have their own negative experience of using community health services, and they may have some doubt about, am I going to bring some changes into the service or not? So it works in both ways. So we have really to be there to liaise both services on one side and the staff on the other side, and to bring them together and start working and evolving in the process of quality improvements.
Well, yeah, as a service user, I think I do have an input, and I think they do listen, which is great. I have found fault for them sometimes when they suggest things, and they take it on board. They don't just laugh you up and say you're service you. They do listen.
The good news is that we have a really good rapport with the CCG, and that makes things a lot easier in terms of trying to do joint working or collaborative pieces of work or projects. So actually it's not been that difficult for us, and I think the reason for that is we have a regular quality review meeting, clinical quality review meeting, and that is really the platform for us to bring our incidents or our themes that we've identified and how we can go about improving. So it was quite an easy sort of discussion with commissioners around, say, our patient experience uptake or our quality of discharge from hospital to community services. So I think the conversation was quite easy because we had the data, and I think the most important thing is that we've both got shared sort of aim or goal, which is about the patient. So I think it's made it easier to bring QI together in terms of ELFT and CCG because we have the same aim, which is patient care and safety.
Yeah, so one example of the benefits of having a wider stakeholder group involved in QI is having all of our commissioners involved. She's been really helpful in helping to set up a new project that we have running with our colleagues at Barts Health around safer and more efficient discharges back home. And that's something I think we would have found much more difficult to kick off if we hadn't had somebody from the CCG sort of gluing things together. And so it's a nice benefit of having people from a number of different backgrounds, a number of different organisations involved in QI, so that you do have enough people who know a bit about the jargon, a bit about how the process works to support that kind of wider cross-organisation working.